Hi all, good afternoon. Today I will talk about the SEEN program, which is about developing and testing an intervention to help people with psychosis to reduce their social isolation. Many of the things that Bryn said would kind of apply to my own background as well. I will, yes, I will probably just focus on some of them and then go a bit more into what is the intervention that we are testing and in general, how is the study progressing. So this study is funded by the National Institute for Health Research, and this is our acknowledgement. So the problem is, as we all know, and is kind of something that in a way is at the heart of our efforts as a network, that people with psychosis are often socially isolated. Social isolation is linked with poor health outcomes, is both in terms of poor psychological outcomes, or also in terms of physical health outcomes. In the NHS, however, people with severe mental illness like psychosis receive medication, they sometimes receive practical support and receive talking therapies. However, there is no evidence, as Bryn showed, that these interventions help to increase social contacts, and we don't have an intervention as part of routine provision that is aimed to improve or reduce social isolation. Okay, so in order to start talking about the intervention and what we are doing with our program, I felt the first step was to think about a little bit how we measure social contacts, because it's one thing is to say, okay, we improve, reduce social isolation, but social isolation is very, very hard to measure and conceptually to focus on. We wrote a paper together with Bryn a few years ago about different ways and concepts behind the umbrella concept of social isolation. I like to distinguish three forms of three ways in which social isolation, social contacts can be measured. So social activity measure, social capability measure, and social appraisal measures. So social activities is how much someone is socially active, meaning how many people someone meets in a week, in a month, how many meetings with others, how many new people they meet, how many group activities they have in a specific time frame. So how much someone is socially active. Another way to look at it is how much is socially, what is the capability? Like in terms of, it is true you might not have met anyone in the previous week or in the previous month, but you have a social network size of family and friends that if you wanted to, you could meet. And the same, you could be part of groups or have a social identity that maybe you have never met someone from your specific groups. I might not have met anyone Italian, but I think I might be able to find some common themes with someone who is from the same nationality or from my same interest group. So this is the social capability. So our interest, the group we belong to, our social network size is something that is in a way an asset that we can tap in just if we need it. And the third one, and potentially the most important one, is how we appraise our social life. Do we feel lonely or not? We can have lots of social contacts. We can meet many people but still feel lonely. And also, as someone was mentioning, we can have many social contacts, but still our quality of life or our perception of social support is still poor. So the way we approach this in SEEN is that we felt that we need to change social activity in order, so particularly for people who have limited social activity, few social contacts, we need to be able to make them more socially active so that their social network size and group membership will increase and their loneliness will reduce and their quality of life will improve. So our first step was how we can make people with psychosis a bit more socially active and help them to meet more people. And the main question, like scientifically, was if we get people to meet more social contacts, would that improve quality of life? We know that people who have more social contacts have a better quality of life. We don't know whether we kind of change the number of social contacts, whether this reflects in a better quality of life. It's a bit like what Bryn was saying earlier about social isolation and loneliness or quality of life are linked, but they're not fully linked. So we need to see what happens if we change that. And also, can a new targeted intervention to help patients to increase their social contacts, would this have this positive effect on social contacts and eventually on quality of life? So we started with a market analysis, with a survey to say how many people might need this, how many people with schizophrenia or with psychotic disorders are really likely to be willing to participate in intervention and to need it. And we've done a quite large survey across different sites in England. And we had 550 participants with an average of 3 social contacts in the previous week. Now, these social contacts are the ones outside of home, work, or services, because we felt that the contacts that you can bump into someone at home, like if you live together, there's a chance you meet them, or if you're at work, there's a chance you meet people. And again, in services, there are interventions that involves contacts with other people, but these are not reflective of how much someone is independently socially active. That's why we just focused on the contact outside of these settings. We found that participants had an average of 3 social contacts in the previous week, and most of them, 63%, had 3 contacts or less, and 70%, interestingly, the participants wanted to have more social contacts, and a bit more than half of them say that they will not be confident. So these people who want to have more social contacts and not confident are the target for the intervention. If someone didn't want to have any more social contacts, there's nothing we can do about it. Really, they will need to be willing to engage with the intervention. I mean, at least with this kind of intervention, there's not much we can do. We need someone who's willing to work with us. Okay, then we did some engagement on a large scale with focus group with participants. We had a number of focus groups and overall 82 participants. We identify what are the main characteristics of an intervention, the generic ones. Obviously, you need to find the right staff member. It doesn't mean to be like psychiatrist, social worker, psychologist. It's just someone who is empathic, whatever their profession, and someone who's able to empathize with potential difficulties that the person has whilst trying to change their social life. Also important to discuss previous negative experiences, which might generate an ambivalence. Many people would want to increase their social contacts, but they also find it difficult. So one needs to understand this sort of dialectic between kind of wanting to do something, but also struggling to do it. And also something seems simple, but quite important, provide clear information about what's available in terms of going out and meeting more people and facilitating the access, things like mobility, transport, how expensive it is to go somewhere. All these kind of things are quite important in practice. And also importantly, there is a balance between supporting someone, but also letting them do things on their own. So very long intervention, or like 2 years, might then eventually create a relationship of dependence rather than what we want. So people independently going out and increasing their social contacts. So we had a long developmental phase with case studies. After we had this focus group that we started with the first very generic draft of the intervention with very senior professionals trying it, and then we got feedback from them, and then we developed a first manual, and then we tried again with more service user, and then again, so it was a number of iterative cycles. And during these cycles, there was an extensive input from our dedicated scene lived experience advisory panel, fully including carers or service user with psychotic disorders. A bit stuck, okay. Okay, so the intervention, what is a social contacts coach? It is an NHS professional with some experience of working in mental health. In the NHS language, this means we just translate it as having a band 4 sort of job or higher or equivalent experience. They work collaboratively with patients in social contacts, and the idea is not to kind of come up with activities that service user could do, but to help them select what they want to do and support through them. And there are meetings over 6 months, and there is an additional, apart from the meetings, there are the coach and the service user can agree at specific times in which service user can give a call to a coach if they're just doing an activity and they need a bit of support and stuff. So there is an option for contact, but just at the point of when someone is trying an activity. It can help because if someone is there and struggling, just to have someone to support them, even on the phone. So this is the structure, 6 sessions over 6 months. And the first 2 sessions a bit longer and then follow up. The principles are patient-centered approach, motivational interviewing, and solution-focused therapy. I will briefly describe how this fits within the intervention, because obviously it's not solution-focused therapy in full or motivation interviewing in full. We just want to kind of embed some principle within the intervention. I have just 2 slides, so but this one.
1 minute, Domenico.
Yes, yes. So the intervention works through 8 steps. So the first is an introduction, and it's important because some professions might want to present this new role, is something new for service user, and also what the intervention will do. And then there is an attention to go through the history of current activity. So what they've done in the past that they're comfortable with, and also what is the motivation for change. It might change across different people. So the idea is that why do you want to meet more people? what are the barriers and what are the things that would make it easier for you. And then one thinks about options for activities. We select one activity that goes on for at least 3 months, so a proper try. If it doesn't work out, then another activity. And so the only intervention is 6 months. So once an activity is chosen, it is tried for 3 months, then otherwise continued, or if it doesn't work, then one chooses another activity for additional 3 months. The intervention lasts for 6 months, but then we evaluate it over 18 months. So we evaluate at the end of the intervention, then we follow up sustainability over 18 months. So at the end of the 6 months, the participants and the coaches put together a plan for the future, which then is left to the service user to continue or to, that's the independent service user is preserved. So the idea of 6 months is because it was enough to provide support, but not too long to create dependence. Okay, and at the moment we're halfway through the recruitment. We're doing the studies in different locations. And if there is any interest, then you can look at our website and contact us, and obviously we will have time to discuss later, hopefully. I hope I give a bit of a summary of what the study is about.
Thank you very much, Domenico. It's very helpful and interesting. A couple of questions actually on the similar theme are, perhaps you could address it. Do you think COVID has made social isolation worse for people with psychosis? And have you found any ways of adapting your intervention?
Oh, thanks. That's a great question, because I was meaning to talk about it, but then I didn't have time. Anyway, so we are looking into online social contacts as well. So we have an idea of how, obviously, the limitation with face-to-face social contacts might have led to changes in online social contacts as well. And in terms of, we had to freeze the intervention for a while, because obviously, like at the time of physical distancing, it wouldn't have been kind of possible to tell people to meet more other people. But now we are adopting a delivery face-to-face through video calls, and also a delivery face-to-face to social distancing, because it is all good and well to say, then we deliver the intervention online, but then there are some people who might not be able to participate to the intervention online. So delivery always have to be kind of partial online, but for people who are not able to access online or good connections, we will still trying to keep some social distancing procedures. So the idea is that online can be ideally a gateway to face-to-face social activity. So our end aim with this type of intervention is always face-to-face social activities, which are available even through online means. But online can be a gateway to it. So like in terms of starting something online, see how it's going, and then eventually, when it's possible, when does face-to-face, like real life, or let's say offline social activities.